Great. Okay, good afternoon, everyone. Thank you for joining us for this year-end webinar organized by Synergex Med and Mental and Brain Health. My name is Oscar, and I'm the marketing manager at Synergex Med, a clinic providing pain management, neurology, and now neuropsychology services in California, Washington, and Arizona. It's really an honor for us to have you here and a pleasure to kick off this event titled The Role of the Neuropsychologist in Head Trauma Legal Cases with our speaker, Dr. Rafi Wold. He's a licensed psychologist and board-certified neuropsychologist, a part of our team at Synergex Med with over 16 years of experience on the field. So before we begin, let me explain the format of this webinar. So we'll start with Dr. Rafi's presentation, and during his talk, all the microphones will be muted and only the doctor's shared screen will be visible. However, the chat will be open for your questions and comments, which will be addressed by my colleague, Amber Andrade. We kindly ask you that you reserve questions related to the presentation for the end, where we'll have a Q&A session with open microphones. So now let's welcome Dr. Rafi Wold to begin his presentation. Thank you so much.
Hey, everybody. Thank you. I'm going to just pull up my presentation here, and we should be ready to go. Okay, good. Is everybody able to see my presentation okay?
Yeah, absolutely.
Is that clear there? Okay, excellent. So we're going to talk a little bit today about the legal side of neuropsychology and what the role of the neuropsychologist is and can be in head trauma, especially head trauma personal injury cases. So some of the things we're going to work on today, we're going to talk about the goals of a neuropsychological evaluation. We are going to talk about the different components that make up a typical evaluation, because it's not just test administration. There's a lot of other components that go into it. We're going to talk about how we interpret basic normative data and what normative data is, and exactly how that pertains to a client with a head injury. And then we're going to talk about neuropsychological profiles, diagnoses, plans of care, how we make use of all this information that we gather, both for the treatment of a client and also in order to demonstrate the extent of a head injury. Okay. So the basic idea of neuropsychology is that we administer a number of different tests. It's not just one big test that every neuropsychologist administers. There are thousands of neuropsychological tests out there, and every neuropsychologist chooses those tests that they feel are going to provide the information that they need, that are going to have accurate normative data, and that are going to be easy to administer to their patients. So when I say normative data, what I mean is we take all this information and we compare people that we evaluate in different cognitive domains. So for example, we look at their memory skills, we look at their episodic memory, their verbal memory. We're going to get more into this in a little bit. We evaluate it. We take their performance and we compare them to other people their age. And then we compare them to themselves based on how smart we believe them to be. And we can be pretty accurate in estimating how intelligent people can be. And based on that, we can get a really accurate picture of how much impairment a person has. So if you guys go back to your college statistics days, you'll remember means and standard deviations, which are the basis. Basically, the way that I want people to think about it for our purposes is obviously the mean is the average, and think of a standard deviation for our purposes as being the average distance away from the average, right? So in other words, the overwhelming majority of people are going to fall within one standard deviation of the mean. Okay, and again, that also I'm going to explain in a little bit more detail. But what we try to understand is not just based on a patient's test performance. There's a lot of other information that we factor into our decision making, including a patient's history, their cognitive profile, which we discussed, the way they talk, the way they walk, the way that they're functioning emotionally, and a number of other different factors. Based on all of this information that we gather, we can come to a solid conclusion on a diagnosis for a patient, a prognosis, and provide a lot of other information for patient care. The goals of a neuropsychological evaluation, whether it's referred by a neurologist, whether it's referred by an attorney, is we're trying to provide a diagnosis if it's not already clear what the diagnosis is. We're going to stage the diagnosis. So in other words, is it mild? Is it moderate? Is it severe? We're going to talk about prognosis and how we expect the patient to do going forward. We're going to provide, and this is something that's really, really important for the legal side of it, is we're going to provide very exact quantitative data. This is all going to be provided in numbers that will show within a number of different cognitive domains, a number of different thinking skills, how a patient is functioning relative to where they were. So we're going to be able to say, you know, they were functioning up here with regard to their verbal memory, and I can demonstrate to you right here, they've dropped exactly this far. And this happens across a number of different domains. We're also working to figure out what the best medications are for the patient, whether they're capable of managing their activities of daily living. You know, they can bathe themselves, they can cook for themselves, they can manage their finances, they can drive a car, whether they need psychiatric care and what kind. Basically anything else that I can come up with or we can come up with that will improve the quality of life for the patient and their family. Okay, so let's talk about the different components of an evaluation. You know, you refer one of your clients for a neuropsychological evaluation. What happens? So the first thing that we do is generally before a client with head trauma, or really any client or patient for that matter, comes into my office, I've done a very extensive review of their medical and social history as much as I can possibly get my hands on. So anything that anybody has regarding their medical history, their accident, their social history, I want to know as much as I possibly can about them before they walk in the room. Then once I greet them, I'm observing everything about them. Again, are there any speech deficits? Are there changes in their gait? Is there anything that I want to examine from a physical standpoint? Is there any neurological deficits that I actually want to kind of put my hands on the patient and see if I'm seeing any neurological signs that I'm concerned about? We discuss the family's complaints, the patient's complaints. I take an in-depth medical history, even though hopefully by the time they come in, I already know their medical history. I go through things with them again, just to make sure that I'm understanding exactly what's going on. Additionally, I want to know their social history. So I want to know where they were born, where they were raised, what the highest level of education they completed was, are they married? How many times have they been married? Are they managing their activities of daily living themselves, or do they need assistance? This is all really important information that I'm going to end up using to put together along with my cognitive data in order to provide a proper diagnosis. Okay. So one of the first things that I do and us neuropsychologists do once testing is completed and the patient has completed their part of the evaluation is I estimate their premorbid intelligence, right? So another term for this is cognitive reserve. How smart and how capable was a person before this accident happened? And I don't mean that in a subjective way. I mean it in a very specific numerical, empirical, statistical way. So I will make a statement such as, neuropsychological testing along with medical history and clinical presentation indicate an individual of overall premorbid intelligence in the average to high average range, at least with an IQ equivalent of 105 to 115 or so. So again, that range, 105 to 115, is going to be my starting range. where I believe that most of their abilities were in or hovering around before they had this accident. Then just a side note, actually, before I go further into the sort of compilation of all this information, is that neuropsychological testing and the length of it can vary wildly. So, as I mentioned earlier, every neuropsychologist chooses those neuropsychological tests that they feel are best suited to their practice, which means that some neuropsychologists feel a desire or a need to test patients for 8 hours at a time. There are a lot of neuropsychologists that still do this. It is somewhat of an outdated way of doing things. I'm 43 years old. I don't want to be tested for 8 hours. And I'm sure that a person that is post head injury and is suffering wants to be tested for that long, even less than I do. So my goal is to gather as much information as is humanly possible in as short a period of time so that the patient does not suffer further. Our neuropsychological evaluations, they range between the time that I'm interviewing them all the way through the time when we're completely done with testing. I would say on average will range between an hour and a half and 2 hours or so, which is on the far short end. Earlier, I had discussed cognitive domains. So when we're doing this testing, what are we looking at? What are these cognitive domains that we're trying to estimate, that we're trying to understand? Has there been a change? Okay. So generally speaking, one of the most important domains here is verbal and semantic memory. That means how well can a person retain information that they are told, whether it's in the form of a list of words or whether it's in the form of a story. The reason that's so important is that very commonly after a head injury, that's one of the main complaints or the main signs of a concussion or of a more serious traumatic brain injury. I also want to know their spatial memory. How well can they see things in space? And once they see them in space, can they remember where they were and what they looked like? Executive functioning is a complex domain, which I'm going to discuss in a little bit more detail so you can wrap your head around it in a little bit. It's a big umbrella term. Naming, the neurological term for deficits in naming is anomia, which is also something that commonly becomes impaired in people that have head injuries. Verbal fluency, is their speech fluid? I will administer at least one measure that indicates a patient's premorbid intelligence, such as reading recognition. Reading recognition means you provide a patient a list of words, let's say 50 words that are of increasing difficulty. And once you get to number 50, it's the most difficult word. Reading recognition is one of the best measures of premorbid intelligence because of the fact that reading is so overlearned. Even if a person doesn't enjoy reading, we all read on a daily basis. We are constantly reading. We read street signs, we read contracts, we read emails. So a person's reading ability and ability to recognize words is one of the best measures that we have of their premorbid intelligence. And then there will be at least one objective measure of psychological functioning. Other areas that are also important but are not the most crucial are working memory. Working memory I'm going to get into more in a little bit. Math, acalculia is the neurological term for deficits in math after a person suffers some kind of neurological insult. Concentration, a person's ability to focus very hard for a few seconds. Sustained attention, their ability to maintain their attention on something for a long period of time. Facial recognition. Praxis refers to the ability to carry out a purposeful action, like putting together all the motions necessary to swing a golf club, for example, or to use your iPhone. Writing, agraphia is the neurological term for deficits in the ability to write, language comprehension, processing speed. That's sort of like if you're buying a new computer, how many gigahertz is the processor? How quickly can they provide information that you request from them? Episodic story memory is similar to verbal memory, but it's specifically with regards to stories or events. Spatial reasoning, that's sort of like the ability to do complex puzzles or even simple puzzles. Fund of information is how much do they know relative to the sort of information they would learn in school. Verbal abstract reasoning, are they able to think in a complex manner using their words? Impulsivity, do they act without thinking? And judgment, do they make poor decisions? I'm going to talk specifically about a couple of neuropsychological tests, just so that you can kind of wrap your head around what goes on with patients when they are being evaluated neuropsychologically. So, verbal fluency is one of the domains that we discussed. One test that we administer with verbal fluency is the FAS. So the FAS is, I'm going to give you a minute, and I'm going to say a letter of the alphabet. When I do, I want you to tell me as many words as you can that start with a letter that I'm going to give you, but I don't want you to tell me any proper nouns, names of people or places, nothing capitalized. The first letter we'll do is F. Give the patient 1 minute to name as many words as they can with F. And then afterwards, you do A and then S. And there's another similar measure where you ask the patient to name as many animals as they can in a minute, starting with any letter. And again, after all these tests are administered, I get a raw score. In other words, the sum of the total number of words they were able to produce. And then I take that information and I statistically compare them to other people their age in order to understand where their performance was. Tests of naming. The Boston naming test is probably the most commonly used ones. This is referred to also as confrontational naming. So you show a patient a picture of a hippopotamus. Are they able to come up with the word hippopotamus? Very frequently, if you have a patient with anomia, they will see the picture, understand exactly what the animal is, what they do, how vicious they are, but they cannot pull the word up. And the NAB naming test, the neuropsychological assessment battery naming test, is very, very similar to the Boston naming test. Other tests of spatial memory, which we discussed previously, there's the Ray complex figure test, which is literally a picture of an extremely complex looking figure. There are different methods of administering it. One very common way is you ask the patient to copy it, and then you take it away and ask them to redraw what they just saw without seeing it. And then several minutes later, sometimes depending on the mode of administration, you ask them 5 minutes later or 20 minutes later to reproduce what they had previously seen. There's the brief visual memory test where you show a patient 6 simple designs at once. You ask them to study it for 10 seconds and then reproduce what they could remember after 10 seconds. You do that 3 times. And then after a 20-minute delay, you ask them to reproduce what they could remember. Hopkins verbal learning test and the California verbal learning test are similar. It's a list of words that is read to a patient, a list of random words. And then at the end of the list, you ask the patient to provide you as many of the words as they can remember in any order. On the Hopkins verbal learning test, you do it 3 times, you do it more times on the California verbal learning test. And then 20 minutes later, you ask the patient to tell you as many of the words as they can remember. And you also provide them, afterwards, you provide them with distractor words and ask them to tell you whether that word was or was not on the list. Test of premorbid intelligence, we've discussed. The test of premorbid functioning, also known as the TOPF, is a list of words that a patient reads that get progressively more difficult. Information, and how much information does a person know from the sorts of things a person would learn in school. So it could start with questions like, who was Martin Luther King Jr.? And it gets progressively harder to questions like, who was Cleopatra? And goes on from there. What is the capital of Italy? That sort of thing. Executive functioning, we have the Wisconsin card sorting test and the trail making test. So I'm actually going to show you what those tests look like in just a minute. But before we do that, let's talk a little bit more about executive functioning. Executive functioning is an umbrella term which refers to all of those abilities which are theoretically believed to be governed and managed by the frontal lobe / prefrontal cortex of the brain. Okay. It involves working memory, which is a person's ability to take information, juggle it in their mind, and give it back to you. or hold it in their mind for later for a brief period of time. So in other words, if I said, hey, Jimmy, can you go into the kitchen, lock the door, pour me a glass of water, and make sure you turn out the lights. So a person with working memory challenges would say, okay, no problem. They'd get in there, they'd pour the glass of water and say, I have no idea what the other things I was supposed to do are, right? Concentration is another executive functioning skill, your ability to sustain focus for a shorter period of time, sustained attention, which is the sort of thing that someone might have to do like in a college class. They would have to pay attention over the course of an hour and 15 minutes, maybe. Multitasking, self-explanatory. Inhibition and impulsivity. Does a person commit acts cognitively that they don't want to commit because their mind isn't able to stop them from doing so? Is there something in their mind that can inhibit them from taking some kind of an action? I'll discuss that again. I'm going to show you a really good test which measures that. Emotional control is very similar to inhibition and impulsivity, but it relates specifically to a person's ability to control their emotions. Shifting, going from one task to another. For those of you that have children, I'm sure you have had experience with problems shifting. So for example, you say, can you please go brush your teeth? And then along the way, they find, they find a toy that they want to play with, and they're just having a hard time shifting from playtime to teeth brushing time. Planning, organization, planning out a schedule well. And planning can even mean something as simple as, if you're going to write out your name, making sure you have enough room on the rest of the sheet of paper in order to finish writing it. Organization and initiation, starting tasks that you have to complete. So this is one of the gold standard tests for the evaluation of executive functioning. The reason I can show it to you is because it's public domain. Most neuropsychological tests these days are owned by different psychological testing companies, and you have to pay to purchase them, and they are copyrighted, and a psychologist cannot release them unless they are with a court order or they are directly to another licensed psychologist for some kind of a legitimate reason. So the trail making test, what you do is you start on the first page where it says trail making test sample. You say, this is sort of like connect the dots. What I'm going to ask you to do when I say go is draw a line from 1 to 2, 2 to 3, 3 to 4, and so on to 8. The patient does so, 1, 2, 3, 4, 5, 6, 7, 8. Then you show them the second page, you explain the same thing, except you say this time it's going to be timed, 1, 2, 3, 4, 5, 6, 7, and so on, until they get to the end at number 25. The normative data is based on how quickly they are able to complete the task. Then there is Trails B. And Trails B actually is one of the neuropsychological tests that is most associated with a person's ability to drive. The research shows that if a person fails Trails B, again, it's not failing or not failing, it's really all relative because we're talking about normative data across a bell curve. But if a person fails Trails B, the likelihood is that they're not going to be able to drive safely. So what I would say to the patient is, you see on this page, I have both numbers and letters. And again, we're looking at the sample. What I want you to do when I say go is to draw a line from 1 to A to 2, 2 to B, B to 3, and so on to D. It's number, letter in order. They do that, and you correct them if they make mistakes, and then you ask them to do the same thing on the trial page, and the normative data, again, is based on how quickly they're able to complete that task. The Wisconsin card sorting test. This is another very popular neuropsychological test. I can't show you the actual test because it's copyrighted, but this is a vague idea of what it is. So you present a patient with 4 cards, okay? Exactly like these ones you're seeing in front of you. And then you put out 1 card at the top and you explain to the patient that I'm going to want you to give me the card that is most similar to the card you see up front, right? So, sorry, hang on one second. Okay, great. So, and then you ask the patient to provide the card that they feel best matches the card at the top. And there are three possibilities if you can look at this, right? So there are three distinctive qualities. There's the number of items on each card, 1, 2, 3, 4. There's the shape of each item on the cards, triangle, star, plus, circle, right? And then there's the color, red, green, yellow, blue. So what happens is the patient will say, okay, I'm guessing he's talking about the color. You put it down and you say that's incorrect because your first category is not color, it's shape. And they say, okay, let me try a different one. And then they say, maybe it's because it's a star. Put a star down, you say that's correct. They say, okay, I got the hang of it. And then you put out another card and they say, okay, I just need to match the shape. They put down another shape that matches. Great. You put down a different card that's a plus sign and they take out their plus sign and that matches. What happens is at some point, without telling the patient, you switch the category. Okay. Once you switch the category, it should take the patient 1 or 2 times or 3 times to recognize the fact that you've switched the category from color to shape or from shape to number. Okay. And people with severe judgment problems have an awful time with this. And it really can provide a quantitative assessment of how problematic a person's judgment is. This is called the Stroop test. The Stroop test, essentially, I'll give you the short version of it, is you can see obviously that there are color words printed here, okay? But the ink that they're printed in, it does not, okay? So what you ask the patient to do is to tell you the color ink that the word is printed in, rather than reading the word out loud. To go down the column and then start the next column as quickly as they can. Patients that have difficulty with inhibition will have a very difficult time doing this, right? So the first one is blue, and then it's red, red, black, red, blue, which can be a little tricky. Obviously, there are different forms of the Stroop test, and there are even some forms of the Stroop test that take it to another more complex level, which unfortunately we don't have time to go into today. And then there's the Conners Continuous Performance Test, which for many, many years has been considered the gold standard in the evaluation of ADHD and problems with inhibition and impulsivity. So the Conners Continuous Performance Test, or the CPT, what it does is it's a black screen and it will flash a letter on the screen. Every 1 to 4 seconds, a new letter pops up. And the patient is told that they are to press the space bar as quickly as possible after the letter pops up for every letter except for X. Okay? This goes on for about 14 minutes. Once it is completed, it provides a number of statistical data points. How many times did the patient commit an act that they were not supposed to commit? How many times did they omit an act that they were not supposed to omit? And it provides a really good sense of whether a person is impaired with regard to inhibition and impulsivity. And again, really the gold standard for ADHD, but also very, very helpful with head trauma at times. Okay. There also is psychological assessment. Some of the important psychological assessments that we administer: the geriatric depression scale, Beck depression inventory, the Beck anxiety inventory. Some of you may have heard of the MMPI, or the Minnesota Multiphasic Personality Inventory, which is basically the most researched test in the history of psychology. It's been around forever. It has had a number of different iterations. And now we're up to, we've gone through the MMPI, the MMPI-2, the MMPI-3. So in its different versions, it provides hundreds of true-false questions. Not only does it provide information about a person's psychological functioning, it also has measures built into it intrinsically that can indicate to the psychologist if the patient is trying to put forward an overly positive presentation or an overly negative presentation. So if they're feigning or exaggerating an illness that they have, or if they're trying to make their lives seem better than they actually are. Personality assessment inventory is helpful in diagnosing, is helpful in diagnosing personality and personality disorders. The NeoPi is based on a system called the NeoAC system. It looks at 5 important personality traits: NeoAC: neuroticism, extroversion, openness, agreeableness, conscientiousness. And in between, it provides a lot of other useful information. The PHQ-9 is very frequently used in primary care as a brief screening of depression, and the GAD-7 is similar, except it's for generalized anxiety. Okay, so further into the normative data. As you can see from here, our mean is right down the middle of that bell curve. Okay, that's the 50th percentile. Every line that you see, the dotted lines that are moving away here, okay, from the mean, both up and down, represent 1 standard deviation. Okay, so if I bring that down here, the mean is the 50th percentile. 1 standard deviation below the mean is about the 16th percentile. 2 standard deviations below the mean is about the 2.3rd percentile. 3 standard deviations below the mean is the 0.1st percentile. So in other words, if you have a person that performs below this range, it means that their performance would be worse than 999 of their peers, of their age peers. And it works the same way going up. The issue is that we neuropsychologists are very nerdy and we don't like to deal with uneven numbers. As you can see, this goes up and down 34 percentage points, and then it goes up 13 or so percentage points and down 13 or so percentage points. We like everything to be more even. So what we don't generally deal in percentiles, though sometimes we do. We deal in other sorts of scores. So a Z-score makes everything even. So it starts with a mean of 50, right? It makes everything a standard deviation of 10. So 40 is 1 standard deviation below the mean, 30 is 2 standard deviations, 20 is 3 standard deviations, and so on. And the same thing in the other direction, which makes it a lot easier to comprehend exactly how impaired the patient is when you do it with standard deviations, and for comparison purposes, it's a lot more useful. Different types of normative data. The one that I would say probably more neuropsychologists use is the standard score, just as I described, except it's a mean of 100 and a standard deviation of 15. These days, when we discuss an IQ, it's with a mean of 100 and a standard deviation of 15. So for anybody who's heard of a child that is in gifted classes, they have to have an IQ that is 2 standard deviations above the mean, which means their IQ has to be 100 plus 15 plus 15 is above 130. And that's the cutoff. If you're above 130, then you're in the 98th percentile and you qualify for gifted classes. Scaled score, same idea, except it's a mean of 10, a standard deviation of 3. The T-score I showed you on the previous screen, mean of 50, standard deviation of 10. Z-score is mean of 0, standard deviation of 1, and percentiles, as I mentioned, the 50th percentile plus minus 34, and then 48 and 49.9. Okay. We also use ranges to describe a person's performance. So, and again, we're going back to standard scores, mean of 100, standard deviation of 15. Anything between 90 and 109, we use the term average. Anything between 110 and 119 is high average, 120 to 129 is superior. And again, 130 plus, you're more than 2 standard deviations above the mean. We call that very superior. And then going the other direction is low, average, borderline, and extremely low. Okay, so I'm going to provide you with sort of an example of how all this works. Okay, so with a client whose personal information has been sanitized for our purposes. So John Smith, 60-year-old right-handed male, He was involved in a motor vehicle accident 4 months prior, and for the sake of time, I'm not going to go into the exact mechanism of injury. But since this time, he's been having chronic headaches, short-term memory loss, word finding deficits, meaning problems coming up with words that he wants to use in conversation. He did suffer a loss of consciousness that is believed to be in the range of 2 minutes. He is taken by EMS to the emergency department, and they do a CT of his brain, which is negative, which is a very, very common finding after a mild traumatic brain injury. He becomes angry with his wife when she discusses his problems in her presence. Doesn't have any history of psychological problems, but again, he's experiencing this agitation, and he's saying the reason he's agitated isn't because he's depressed, it's because he's bored. Okay, medical history is significant for gout, diverticulitis, reflux, osteoarthritis. He had a right knee replacement, basal cell carcinoma excision, and a herniorrhaphy. So the more important part that I want you to understand here is that he does not have any major vascular risk factors. Vascular risk factors are basically any of those factors that make a person at a higher risk for stroke or heart attack. And the reason that that's important is because any vascular risk factor increases a person's chance for developing the two most common causes of dementia, which are Alzheimer's disease and vascular dementia. They are both they both are associated with vascular risk factors. So this guy is, for a 60-year-old, is reasonably healthy. Born and raised in Brooklyn and lived in Long Island. He's a pretty smart guy. He has a bachelor's degree from NYU. Again, this is another piece of information that we have to indicate to us what his premorbid intelligence was. He worked as a CPA, married for 32 years, 2 sons living in the New York area. Behavioral observations, his gait was within normal limits. He's not limping. He doesn't have what we call an ataxic gait, where some kind of a nerve or neurologic issue is interfering with his ability to walk. When he speaks, you can notice that he's having a hard time. And again, to the untrained eye, some people might not notice it, but when it's observed a certain way, you can notice that he's having a hard time coming up with certain words when he's speaking. He was generally happy when he was supposed to be happy when we were discussing positive things, and unhappy at other points, but he became clearly agitated when he realized he was having a tough time in certain areas. Okay, so now let's look at this data again. So keep in mind, we're talking a mean of 100, standard deviation of 15. Reading recognition, which is our measure of premorbid functioning, is a 112. Verbal fluency, 98. These are our neuropsychological measures. Okay, so his verbal fluency performance was a 98. Naming is a 75. These are his verbal and spatial memory scores. Okay, so this is immediately when I present him with words, after a 20-minute delay when I present him with words, and when I ask him to recognize the correct words among distractors. Spatial memory. Immediately after seeing a design, how well does he draw it when I take it away after a 20-minute delay? And when I ask him to recognize it among other designs that were not there. His attention performance is a 108. Executive functioning is an 82. Fund of information, again, another good measure of premorbid intelligence, is a 110. Psychological testing is negative for any clinically significant psychological problems. So what we did here is I put in red anything that was, so I estimate, let me take a step back. His reading recognition, our measure of premorbid intelligence, is a 112, okay? Based on that, my fund of information, okay, which is another premorbid measure, okay? Also, based on his level of education and his work history and everything else that I know about him, I'm able to come to a conclusion that his estimated premorbid intelligence is about a 110, which is two-thirds of a standard deviation above the mean. That's a pretty smart person. So what I did is, with this as a jumping off point, the estimated premorbid intelligence, I outline here which areas have fallen and how much have they fallen. So if it's less than a standard deviation below where it should be, I'm less concerned about it. Those are in green. His verbal fluency, his verbal fluency and attention are less than a standard deviation below the 110 mark. His executive functioning is between 1.5 to 2 standard deviations below that area. Okay. His naming and all of his verbal memory and all of his spatial memory have fallen more than 2 standard deviations below this range. Again, we're starting at 110 with a standard deviation of 15. So 110 minus 15 is 95, minus another 15 is 80. So that means that anything below 80 represents a decline of more than 2 standard deviations from his premorbid intelligence. Okay. Right, so we'll talk diagnosis, treatment, care, and planning. So the diagnosis is post-concussion syndrome. One of the things that's important to bear in mind here is that he's 4 months post-MVA. Being that he's 4 months post-MVA, most of the cognitive recovery that occurs from a head trauma will occur at most between 6 and 12 months after the injury. So, and that includes a stroke or a head trauma. So we're at 4 months. So there still is the chance that he can continue to gain some of his functioning back, though it is concerning that we're at the 4-month mark and he's still this impaired. So the diagnosis is post-concussion. Excuse me. How do I go backwards here? There we go. So we call it post-concussion syndrome, and the stage is mild to moderate because of the fact that he's able to still manage what we call his BADLs, his basic activities of daily living, showering, shaving, putting on his clothes, managing his own personal needs. And that's in contrast to what we call IADLs, instrumental activities of daily living, driving, cooking, managing finances, things that are a little bit more complex. We mentioned earlier that the trail making test is one of the best measures of driving capacity. And with his trail making test, like I mentioned earlier, okay, so our measure of executive functioning is right here. Executive functioning in yellow between 1.5 to 2 standard deviations, okay? That's our best measure of driving ability, okay? Based on that, there's a pretty fair likelihood that he does not have the ability to drive. I would recommend that he undergo a driving evaluation. If he feels comfortable driving and wants to continue driving, a lot of times people will say, I can't do it. I can't do it, and I'm scared to get behind the wheel because I can tell I'm not doing it well. Some patients don't have that recognition, and in those cases, I would strongly recommend that they have a formal driving evaluation with a driving instructor. My objective measures suggest that he probably should have assistance, especially with medications and finances. Mismanagement of medications obviously can have catastrophic effects. If there are mistakes, exercise, socialization. Exercise is one of the most important things we can do to keep our brains healthy. And based on all this, we provide the court with an exact quantitative display of how impaired the person is directly as a result of his injury, again, because of the fact that we know what his premorbid intelligence is, right? So we're providing cold hard data that quantifies how much a person has suffered because of the injury. With that, I will wrap up, and I'll take any questions that people might have.
Hi. Sorry
Hi,
to
Dr.
Sorry
Velazquez,
about that.
how are you?
sorry to bug you. Thank you for the talk. That was super helpful. I appreciate it. I had a couple questions and I'm hoping I can pick your brain about it. Um, uh, I agree with a lot what you're saying. I'm also a neuropsychologist. And I had some questions about, I noticed you don't incorporate IQ into the evaluations, or maybe you do, you're more focused on pre-morbid. And so I just wanted some thoughts on when you do or don't. And also when you decide to use a MMPI versus just primary measures. I go back and forth on how much I should delve into the psychiatric aspects and lingering components. But my main question was pertaining to non-English speakers and how you assess premorbid, and then when people have dyslexia when we're using a reading measure.
Awesome questions. Wow. Okay. So let's start with the intelligence. Well, don't go anywhere because I'm going to need you to remind me of all those questions you had. So, with regards to the intelligence testing, the most commonly used, by far the most commonly used intelligence test by neuropsychologists is a test called the WAIS, the Wechsler Adult Intelligence Scale, which is made up of 10 different subtests. And administration generally takes about an hour to an hour and a half. And when I'm trying to keep my evaluation as short as is humanly possible so that I don't torture the patient while still gathering all the information that I need, if I'm only doing an hour to an hour and a half of testing, I don't want those waste subtests to consume the entire session because they don't provide most of the information that I need. On top of the fact that an overall IQ that is provided by the WAIS might not provide an accurate depiction of the person's intelligence because some of those measures will probably be affected by the injury.
Correct. And I'm
Right.
just curious about like testimony if you had an issue with not incorporating an IQ.
I've never had a problem with it. I personally am not a huge fan of administering a whole WAIS. Again, because of the fact that I try to keep my evaluations on the shorter side. If I was going to evaluate a person for 6 hours, then I probably would include an entire WAIS in it. But I just don't. There's no other medical specialty on planet Earth where a patient will sit directly in front of you for 6 hours in order for you to figure out what's wrong with them. So there's no reason that we should either, right? Obviously, it's a little bit different and we do need more time, but 6 hours is excessive. So we're trying to get as much information as possible. And the majority of the time, the reading recognition tests like the TOPF and information from the WAIS are going to provide us a better estimate of a person's premorbid intelligence than an overall WAIS because of the fact that they are impaired, if that makes sense. Right? Other question in terms of Spanish, I am a fluent Spanish speaker. So obviously you can't give a reading recognition test. There are receptive vocabulary tests that are good measures of premorbid functioning for non-English speakers. I like to use matrix reasoning, which is a measure of spatial reasoning for people in order to gauge their premorbid intelligence. But there's also if you do a lot of Spanish-speaking neuropsychological evaluations, there's also the bateria cognitiva, which provides individual measures of cognitive functioning in Spanish.
Yeah, my issues with those is the normative data is racially, ethnically normed. So I'm just, what I've been doing is protocol in Spanish using US norms and just saying that in my report. And then the WOTS-E is the equivalent of the NART, right? But like I don't really like it, so and it's kind of hard to hear those accents. So
Yep, that's definitely the case. Good
but thank
question.
you, that was helpful.
My pleasure. Thank you.
Thank you, Mrs. Carmen Velasquez. We next, Dr. Rafi, have the question from Annabelle. She asks, would you suggest that this neuropsychological testing be done 9 to 12 months post-loss?
So that's a really good question. if you have, if the main goal is to evaluate where a person is going to be going forward and what their functioning is going to be, what their functioning is going to be going forward for the rest of their lives. The best and most accurate depiction of that is going to occur about 12 months post accident. If you're trying to demonstrate, in order to help your client get the compensation they should get, then you want to do it on the earlier side because they will become less, hopefully, they will become less impaired as time goes on. If you want to demonstrate what the extent of the injury was early on, right? So how much they suffered before they started getting much, much better. So generally speaking, yes, 12 months later is going to provide a better picture in the long term, but in order to demonstrate the extent of an injury, it can be helpful to do it much sooner. Great question. Really good.
Thank you, Doctor. We still have time for the Q&A section. Are there any other participants?
I have another question, if that's okay.
Yeah,
Sure.
Yeah. So I know with like concussions, and I think like the sports concussion world, we use a lot of the impact, the sway. And so I know we do like when a person has it, especially with the headaches, doing more of that concussion model. And with the neuropsych eval, is there a point, do you just only do neuropsych, or is there a point where you switch to one or the other? Any recommendations on that?
When you say one or the other, you mean?
Just sticking to like concussion evaluations in terms of just like vestibular ocular systems versus actually starting with the neuropsych eval. No, I know we talked about what point do we start the neuropsych eval, and you kind of said like earlier rather than later. So I'm just wondering, and with the person's headaches, when do you just decide, or, some people will push through the headaches. I also don't want to make their symptoms worse. So I'm just wondering what just practical recommendations you would recommend.
Sure. So with sports concussion specifically, doing a full neuropsych rather than an impact test, for example, which is like a brief screen that's computerized. I, generally speaking, until it's gotten beyond the point where it's 2 or 3 weeks post concussion, I don't recommend neuropsychological testing if it's a sports concussion injury, because the overwhelming majority of those will resolve within 2 to 3 weeks. Once a person gets beyond that period of time and time drags on, and we're into post-concussion syndrome range, that's a good point at which you want to do a neuropsychological evaluation to try to understand what's going on, why the patient's symptoms are continuing on for such an extended period of time, and gaining insight into what's impaired. So that's the way that I approach that.
And this would be the same with like someone with a recent MVA, wait 2-3 weeks. Okay.
Generally speaking, yeah.
Okay.
Yeah, generally speaking, that would be the case. I would say doing a neuropsychological evaluation within 2 to 3 weeks of a motor vehicle accident does not have the same benefit.
Thank you so much, Dr. Rafi. We also have another question from Vanessa. She says, Doctor, can you explain the difference between a patient with cognitive deficits versus one with somatoform disorder? What do you recommend to determine if a patient has somatoform disorder?
I'm sorry, what was the disorder that you said?
Somatoform disorder?
Somatoform disorder.
Somatoform disorder. Yes, thank you.
Okay, good. So, and I'm going to assume that, so somatoform disorder is one of a group of disorders in which a patient has, along with conversion disorder and hypochondriasis, or different kinds of descriptions of different illnesses in which a person either is actually demonstrating legitimate signs and symptoms of real injury or real illness, even though the illness is not present, or they are overly concerned that again, this is this big group of these disorders, somatoform conversion disorder, Or it might be like with hypochondriasis, it might be that they are so worried that they have a certain condition or a certain injury that um, they're kind of like almost forced, they're almost willing themselves to have those issues. Um, so with those issues, I think the most important thing to do is if you're suspecting that sort of an issue, I think that's a really important reason why one thing that I didn't cover just because we didn't have enough time. An important thing to do is to administer, and it has to be a component of basically every legal evaluation is a validity test. We call an SVT a symptom validity test or a PVT a performance validity test. What those tests are is they're measures that evaluate if what the patient is, and you may have heard of these and you may hear the word faking if a patient is faking. That's not the right word for it because very often patients don't do well on these, and it's not because they're faking. But what those tests help us do is they help tease out if a person has a genuine, organic medical issue that is responsible for what they're experiencing it at the time, or whether it's something like somatoform disorder or conversion disorder that is more of a psychological issue that is responsible for what the patient is experiencing. Much more frequently, a patient with a conversion disorder, somatoform disorder, will have a positive result on a validity test, whereas a patient with genuine medical issues will quote unquote pass the validity test. So that's one of the most important things you can do. And then, but also you really would need to alter the nature of the evaluation if you were suspecting somatoform disorder. You need to look more into other measures like the MMPI and the PAI, the personality assessment inventory. And there also are really specific measures out there. There are hundreds and thousands, not hundreds of thousands maybe, but hundreds and thousands of different psychological and neuropsychological tests out there. And there are ones that are really geared specifically towards evaluating for somatoform disorders, conversion disorders. So that's something that I would work into that sort of evaluation if I felt that there was a likelihood that a patient was experiencing a somatoform disorder.
Thank you so much, Dr. Raffi. We got right here another question from Heidi Campbell. She says, can all these discussed tests be completed via telemed, or is it best for the patient client to go in? I know some doctors simultaneously complete brain tests as well. Is the brain required, or can we still demonstrate the extent of their injuries without it?
Great question. So, since COVID and the advent of much more telehealth than we had in the past, there's been a lot of advances in neuropsychology. There should be more than we have, but there have been a lot. And that's why at Synergex Med, I've worked to create an evaluation that can be administered remotely via telehealth. So, so our evaluation can be done via teleneuropsychology. That's what we call it. So I have tests that I've chosen that work very well via telehealth, that provide me the information that I need from a patient that are comfortable for the patient to do as the examinee. And again, the whole process, including the interview, I would say takes between an hour and a half and 2 hours.
Well, I believe that was our wrap-up questions. I don't know if someone else have another one. Okay, looks like I know.
Yeah.
All right.
So much, Dr. Raffi.
My pleasure. Thank you so much for having me.
Yeah, as we close the Q&A session, I just want to thank you again for attending and thank you so much, Dr. Rafi. I will also like to mention that tomorrow we will share this recorded session to the email addresses of all those who register in the registration form. But if you access it by another method other than a registration form, you can send us a direct message on our social media networks or request your copy of this webinar by writing to us at marketing@synergexmed.com. Thank you very much, everyone, and have a good rest of your day.